Good afternoon, everybody. Thank you so much for joining us here today. My name is Mike Lewis, and we're going to get this webinar started. There's a lot of information here. So today we're going to go over the 2024 MIPS measures, new measures, changes, scoring, and everything you're going to want to know about MIPS measures. So joining me today are our measure wizards. They don't like that name, but Tara and Josh will be running us through most of this presentation after I hand it off in a little bit. They have been with Health Monix for what seems like forever, and they are in charge of putting together all of our measures every single year and updating all new measures. MIPS quality measures. All right. So a couple things about the webinar that are in front of you. We have in the GoToWebinar widget, which just changed, so it may look a little bit different, but there's the ability to ask questions as well as the handouts for today. All of the handouts are here, and I will be sending them after the webinar as well. You'll get the handouts as well as a copy of the video of the presentation, a link to it. Please ask your questions. If we don't get the opportunity to answer them during this meeting, we are usually very good at getting back to people in the upcoming days after the webinar. So what are we going to be going over today? We're going to be talking about new quality MIPS measures and changes. We're going to discuss the new measure benchmarks for quality reporting, very interesting insights into those measure benchmarks. And then we're also going to take a little bit deeper of a dive into the decoding the quality measure scoring. Just for everybody to know, this is a little bit more of an advanced webinar than our basic webinars. The people that we have talking, Tara and Josh, are very skilled deep into these measures and are going to be providing information that may not be suitable for someone that is new to MIPS. However, we do have other webinars that are still out there available on our website for you to go and check out. All right. So why is this important? Why are we doing this today? First off, measures change every single year. The quality measures change every year. The inventory changes, so there's new measures. They've been around 200 or so CQM, ECQMs over the last 5 or 6 years, but it does fluctuate up and down a little bit. And there are definitely areas where CMS is trying to get the quality measures that are deemed important to them. Specifications on those measures change very often. You'll see later on that many of the measures have at least a little tweak, but some of them have substantial changes to them. There was clinical evidence updated in the measure. Billing and medical coding has been updated. The big one was back when they did the ICD-9 to the ICD-10 coding. That changed every single measure. But from then on, we do have a lot of measures that have that. Measures are clarified, so sometimes they aren't tested as well as we would like in the beginning from a CMS standpoint, and they add areas. I know, for instance, another area of big change was telehealth. As telehealth became more popular, many of these measures needed to actually call out whether it was good for telehealth or not. So now that is part of each of the measures and also part of any new measure that comes out. Scoring of the measures updated, so they need previous history for the quality measures for them to give adequate scoring. So they use the scoring from 2 years ago. So new measures don't have benchmarks yet for the most part, but there are some benefits to reporting them. And then those benchmarks are changing every year. So when providers and groups and clinicians do very, very well on measures, they become harder to score, very similar to having your score in high school on a curve. If everybody's scoring 100, is the test really worth 100? And then the quality payment program is becoming more challenging. I think you'll see not only from here that the thresholds and requirements are raising, but measures are focused more on outcomes. So, you go from measures when we first started with this, which, pneumonia vaccine or flu vaccine or smoking, where it basically just asks you, did you ask this to a patient? Now they're looking for challenging questions. Did the patient get better? Did their numbers change? Did you follow up? What are the instances and what does it look like that? And that is where the changes are, and this becomes a lot more difficult. So right here, before I get into the next part, I have two polls that I want to ask people. And I'm going to just ask you if you could quickly answer the poll so that we can move on. But let's go with the first poll real quick. Give another 10 seconds or so, so if everybody can get their answers in, that'd be great. Great, thank you very much. Sharing the results here. For the most part, everybody is in the confident to very, very confident to somewhat confident range. But there are people that are in, not confident all the way to neutral. That area, this is really a great time to do it. You're still very early to the game in 2024. To get a better understanding, we do have a lot of material between blogs as well as webinars, and we do offer consulting as well through some of our partnerships to be able to give you a little more insight into what you are needing to do. One more question, and then I'll keep going on. Let's do this. Which reporting mechanisms are you currently utilizing for MIPS measures in 2024? Great. Thank you very much. Seems like a majority of people are reporting through their EHR or through a partner here at HealthMonix as well, registry reporting as well as a QCDR. So thank you for this feedback. It really helps us as we're building future material for this, as well as helps our speakers today as we move on forward. Understand your quality performance category reporting requirements. So just a little bit of background on the basics. There are four components for 2024 MIPS. For traditional MIPS, you have the quality, which is 30% of your score, cost another 30%, and then improvement activities at 15 and promoting interoperability at 25%. It's important to understand that that changes based upon the size of your practice, whether you are eligible for certain categories. A lot of people are exempt from, for instance, from promoting interoperability, and that changes based upon the size of your practice. So understanding your quality category reporting, quality performance has a 12-month period. So it is from January 1st to December 31st. You must report and collect data for each measure for the full calendar year. Quality reporting requirements are determined by your MIPS reporting option. So the big ones that we'll talk about today, we're kind of leaving the APP and ACO off the side as we do other webinars on that. We're really concentrating today on the measures do equate to those programs as well. However, today we're going to be concentrating on some really specialty measures as well and showing you traditional MIPS and MVPs. So for traditional MIPS, what you need to report on is either 6 quality measures, including an outcome or a high priority, or you report one complete specialty measure set. If the specialty measure set includes fewer than 6 measures, you'll meet reporting requirements if you report all of these measures. There's not a ton of those available anymore, but they used to be very popular. For MVPs, it's now selecting a minimum of 4 quality measures, including 1 outcome. They need to be chosen from the ones that are available in each of the MVPs. MVPs are a big way for us to move forward in the future, as they are going to be more mandated moving as we move closer to the next 5 or 6 years. For small practices reporting through Medicare Part B claims, don't recommend that at all, but you do not need to report additional measures in there. Quality measures are determined by your MIPS reporting options. For traditional MIPS, there are 198 measures, and there are over 200 QCDR measures, of which HealthMonix has about 50 of or so of those as well. And each MVP includes a subset of quality measures. So you can't, if you're going to do an MVP, you can't choose measures that aren't available under that. All right. So I think that is one more slide for me. Sorry, one more slide for me. But you should start collecting your data on January 1st. Obviously, we're on the leap day today, but you should include data all the way from the beginning of the year to meet data completeness. If you fail to meet data completeness, you will get 0 points, and it will be still 3 if you're a small practice. So you still need to do it. Data completeness requirement increased this year to 75%. Data completeness refers to the volume of performance data reported for the measure eligible population. So for some of these populations, that's going to include every instance or every instance for a patient, and some is once per patient per year. Others have other criteria, but you should really look into what the performance and what the threshold rates that you need to look at. Selectively reporting your data misrepresents your performance. CMS calls this cherry picking. They are very adamant that you should not do that, and that would be a big check mark for them to look when auditing. So we don't suggest you do any type of cherry picking when you're doing your measures. All right, I'm going to join you back at the end of the broadcast here, but I'm going to turn it over for 2024 new measures and changes to Mr. Josh Hall. Go, Josh.
Great, thanks, Mike. So Mike referenced earlier, why are all these changes taking place, and why do we have new measures? It would seem after all this time that basically we'd be all out. We've already covered everything. Well, of course, there's new measures every year because there's always advancements in healthcare, and we need to address those priorities. New measures also reflect evolving evidence-based practices as the landscape of healthcare delivery transforms, measures need to transform along with it. Um, these new measures ensure that reporting captures the best practices and areas of improvement. This is the same reason why measures are updated every single year, and why not only do codes change, but the actual practices involved with the measures change as well. And by incorporating new measures, organizations can also demonstrate their commitment to staying on top of these things, to staying on top of quality improvement, and to staying current with what's going on in the industry and not to fall behind. Um, so why are then measures removed? Um, Again, Mike noted that one of the big reasons measures are removed in a given year is because they are topped out. When they're topped out, that means, okay, well, everyone's acing the test. The test doesn't seem like it's very useful anymore. So you can see that for 2024, there are 5 different measures that are being removed simply because they're topped out. There are a couple measures that are duplicative to a new measure that's been released, as well as current quality measures. They're over time, as people use measures, they start to realize, okay, well, these are very, very similar. So they're less fruitful in reporting. There are also occasionally measures that simply did not get as much traction. So it makes it difficult to attribute actions to clinicians, and it creates a burden for those who are trying to report them. Here's a quick list of the measures that are removed for 2024. For those of you who have done MIPS in the past in any way, shape, or form, you can notice there are some popular ones on here. However, measures like 110 and 111, they are not going away. There's a new measure that is a composite of all the preventive measures, which we'll be talking about later. And 110 and 111 are going to be reported along with measures like 226, smoking cessation in that one. You can also see that there are a handful of measures that are appropriate for given specialties, such as dementia. Um, Bunch of these measures, as we noted before, were due to being topped out. They had reached the end of their life cycle, so it was time to move on and focus on other measures that will be more fruitful for reporting. There's also a few measures that were just removed from traditional MIPS but are retained for MVPs. Um, these are the following measures that are also, all three of these are incorporated in the new composite measure for 2024. They're also reportable via MVPs. So these are measures that you can still report. However, they are only via MVPs and you can't report them individually for traditional MIPS. So measures do undergo changes. Sometimes these changes are pretty substantive. Uh, Often, the reason for substantive changes have to do, again, for changing guidelines about, okay, what is actually the best way to treat patients um, in this instance. Some of them have to do with actual added strata. So we want to really dig in and stratify this measure, and that's considered pretty substantive. If you're reporting more performance rates, that's more of a burden for providers in order to supply that data. And then also, it really changes what the measure is providing CMS, how they want to dig into those measures. Um, there are often cases too where numerous ICD-10 codes and SNOMED codes and other codes change year to year. And those are pretty substantive as well. If you're used to reporting certain sets of codes and those go away, or if there are new ones that are added, um, those will definitely change the population, the denominator, and the numerator of these measures, um, such that they look different from year to year. Um, when we looked at all of the measures, we identified, along with CMS, if you take a look at the final rule, uh, 59 quality measures that had substantive changes, and 3 of them that have ones that won't have a historical benchmark. We just noted those below. Generally, when reporting measures, unless you're a small practice, benchmarks are important, and we'll be diving into the benchmarks pretty soon. So there's a few measures here that don't have a historical benchmark, or that the measure has changed enough that the benchmark is no longer applicable. Um, To dive into a little bit more about substantive changes for measures, I'm going to hand it over to Tara.
Thanks, Josh. So over here, we have a list of, I believe it's about 11 measures. As the measure team here at HealthMonix, we went and did a deep dive into each of the changes that CMS identified um, that each of the measures had. And these 11 are the ones that we identified as having really the most substantive changes. So if you are reporting any one of these measures in this list, I would recommend that you take a look at the updates that CMS has made, and it may affect your populations and your numerator performance as well, based on the changes that have been identified. This slide is going to talk about what an example is of a substantive change. The measure that we're going to be diving into is measure 134, and that measure is screening for depression and follow-up plan. So this measure is reported as a traditional CQM and ECQM as well. And in the past, patients that had a diagnosis of depression in the history of that patient, those patients were not eligible for this measure. In 2024, this exclusion criteria has been updated to now, um, I'm sorry, also patients with depression and or bipolar disorder were excluded from the denominator for this measure. For 2024, for all collection types, CMS has now deemed it appropriate to keep these patients who are depressed in the denominator for this measure. And that's because if a patient is depressed, they do need to be continually rescreened, and follow up is required if they are persisting with that depression diagnosis. However, they are retaining that if a patient does get diagnosed with bipolar disorder, they will be excluded still in 2024 from that denominator. Additionally, CMS is trying to make this measure more applicable for an expanded list of specialties. So there are new CPT codes that are included to identify qualifying encounters. Those CPT codes are really those that are leveraged by the nutritionists and dietitians and home-based healthcare. These are specialists that CMS has identified as they should be allowed to have eligible instances for this measure and be giving them really a leg up in being able to report this measure. This is a table giving you an inventory that was finalized at the measure level for the 2024 performance year. So you'll see that there are 11 CQMs that have been added, 10 have been removed, 51 with substantive changes, and there are 173 measures that are going to be available for selection for the performance year of 2024 for MIPS CQMs. We also do have a breakdown for the ECQMs, the CSVs, and the administration claims as well. It is it is not uncommon to see at the end of the year that sometimes measures can be suppressed or there's a truncation that is applied to that measure. When a measure is suppressed, they're eliminated from scoring for the performance year. But more often, what we see is that there's a truncation on that measure, and that means that you're only scored on eligible instances for a portion of that year. These two decisions really are driven by ICD-10 coding updates, and CMS then will identify measures that would get affected by those ICD-10 coding updates and then send out communication to vendors whether those measures are suppressed or truncated. In the past, there was a very strict rule on if there was a 10% threshold of coding changes that it would trigger measure suppression or truncation. However, in 2024, they've added a provision that allows CMS to assess the impact of those coding changes on a case by case basis and also at the collection type level as well. So, for example, if a measure can be reported as a CQM or an ECQM, CMS can identify a CQM version of that measure to be truncated, but not the ECQM. And for benchmarking, I'm going to pass it back to my colleague Josh, and he's going to take it from here.
Thanks, Tara. So let's dive into benchmarks. Benchmarks, when it comes down to it, are just as important as the measures themselves when you're thinking about, well, how many points am I going to get scored for this measure? I got a 70%. Well, what does that really mean? So benchmarks are this point of comparison to score the measures that you submit. When you're submitting these measures, your performance on each measure is assessed against the benchmark to determine how many points you earn. These measures can be scored that are scored against benchmarks earn between 1 to 10 points. It is possible to get 0, but let's face it, you're not going to be submitting a measure likely that's going to get 0 points for you. How are these benchmarks established? Well, first off, there's benchmarks for all the different types of measures. So for example, you might have a measure that's applicable for both a CQM, MIPS clinical quality measure, and an ECQM, the electronic version. Those benchmarks might be different because they're reported in different ways, and often The ECQMs are more challenging to report because it has to be end-to-end reported. Therefore, the benchmarks are going to be more lenient and give you more points, even if the percentage met for a given measure is lower. So, historical benchmarks. In order for a benchmark to exist, there needs to be a record of data in order to establish that benchmark. So, for example, for 2024, the 2022 and 2024 measure specs must be comparable, i.e. there needs to be no significant changes to the measure between 2022 and 2024. So as I mentioned before, if a measure has a bunch of strata added to it, or if there are too many codes that change from year to year, or perhaps they change the denominator too drastically, then the benchmarks aren't comparable. You can't really compare apples and oranges if you feel like the measures change too much year to year. Um, in addition to that, 20 instances of the measure must have been reported in 2022 through the same collection type. And this includes individual clinicians, groups, virtual groups, etc. In addition, we can see a few more requirements here. Those groups need to be eligible for MIPS in 2024, i.e. no changes to low volume threshold in 2022. The measure met performance here for 2024. Data completeness needs to be at least 75% with a minimum of 20 cases. And the measure had a performance greater than 0% or less than 100% for inverse. So scoring against a benchmark. As I noted before, these are the requirements to even get scored against a benchmark. So you need to hit at least the 75% threshold for the measure. You need to have at least a minimum criteria. Generally, this is 20, and the benchmark needs to exist. So what if you don't meet that data completeness criteria? Well, you'll get 0 points, even if it exists. However, you can still earn 3 points if you are a small practice. If the measure doesn't meet minimum criteria, even if a benchmark exists, again, you'll get 0. Small practices earn 3. However, there are exceptions to this rule. Measures that are in its first or second year in the program, measures that haven't had that time in order to create the benchmark, because you do need that 3-year period. If the measure is in its first year, you could earn 7 points by default, and second year, 5 points, as long as you meet the data completeness. Do note that this doesn't apply to administrative claims measures. So again, we're just trying to hit this home here. If a measure doesn't have a historical benchmark, what do you do? Generally, what we recommend people is we recommend you to choose measures that have benchmarks. It's not only important to get more points, but the whole purpose is to see, okay, well, how does my practice, how do my providers stand up versus all the other providers reporting MIPS, all the other providers out there. So seeing where you stand in those benchmarks is important to improve your own practices and to give you an understanding of how you're doing. However, as you can see over here, just in terms of points, in terms of data completeness, these performance period benchmarks can be established when at least 20 instances are reported, so you need to have enough data, and that the performance is greater than 0%, which basically means you have to have at least met the measure once. Individuals, groups, virtual groups, these are all eligible for 2024. This includes individual clinicians and groups that are opt-in eligible and elect to opt in to MIPS participation, and voluntary submissions are excluded from benchmark data. And at the bottom, again, if a measure has no benchmark, small practices can still earn 3 points, and the measures in its first or second year will earn 7 and 5 points respectively. So measures are scored against a benchmark by falling into one of 10 deciles. Uh, and they can get um, different amounts of points within those deciles, depending on what the performance is. So um, I think the easiest way, and Mike alluded to this earlier, is kind of thinking this as a test. Um, if you've got a 55 on the test, you might get somewhere, if all the deciles were simply the same amount. So for example, uh, diabetes, A1C, measure one, the measure that's been with us the longest, the deciles are evenly distributed. Um, so if you score 50% on the measure, you'll fall into decile 5 and get 5 points. Um, most measures, if are a wide range of deciles, and all of this decile information is dependent on how providers have scored on these measures previously, how this data has been compiled over the last 3 years. So it might be really challenging in order to get 9 points or 8 points um, if a lot of providers previously and all the data suggests that, hey, everyone is acing this test, therefore you need to basically ace the test in order to get any amount of points or do well on the test. And we're going to look at a couple examples here. So in this first example, we're taking a look at measure 9. And here, we're not going to dive into the formula down here and the math of all of that. But here we have Dr. Johnson. They submitted data for measure 9, and they earned 3.4 points, but had a performance rate of 75.28. This is because that performance rate fell into um, the decile of 3. So we don't have all of the deciles in front of us here, but essentially the deciles were ordered such that decile 3 contained the performance rate of 75.28. Therefore, Dr. Johnson fell into that. We can see that there's some math there, and that averages out to 3.4 points. One thing to note too, all of the benchmarking data and all these deciles are freely available to download from CMS and from our sites as well. The resources are right there, so there's visibility into how all these numbers come to play. Another example here. So Dr. Johnson's also submitting measure 317. In this case, it was a claims measure, and it resulted in a performance rate of 100%. So you might think, well, wait a second, why don't I get 10 points? I should get the maximum points for 100%. Well, measures can also be topped out. If a measure is topped out, this means that, hey, again, providers are doing really, really well on this measure, and we are going to flag this measure as being topped out, which essentially means if you ace the measure, if you get 100%, the maximum amount of points that you can get is 7 instead of 10. So it might still be beneficial for your practice to use a topped out measure if you know that your providers are meeting the measure on a consistent basis. And you're like, well, 7 points is 7 points. That's still a good amount. However, there's no way to get 10 points for a topped out measure. Inverse measures. Quite simply, inverse measures are flipped. So for example, for measure 1 for your A1C levels, measure 1 is looking to make sure that the A1C levels of patients are not at a certain range. Therefore, and we're going to be going into met and not met in a little bit, you want to get a high performance rate for this, or I mean a low performance rate. You don't want your patients uh, to be meeting the measure. So essentially, they're just flipped. So instead of trying to get 100% on a measure, you're trying to get a 0% on a measure. And the last little bit here before I'm going to pass it over to Tara. Are all topped out measures capped at 7 points? Well, no. A measure is capped at 7 points once it's topped out through the same collection type for 2 or more consecutive years. The 7 point cap is applied in the second year when it's identified as topped out. So it's kind of like a warning sign. The very first year that a measure gets topped out, they're like, hey, a lot of people are using this measure. A lot of people are succeeding at this measure. That's great. However, if this pace continues, that means the following year it'll be capped at 7 points. There's a couple examples here between measures 47 and 130. For measure 47, um, if it's topped out and it doesn't have that 7 point cap, you can still earn 10 points this year. However, in its second year that it's still topped out, it will be 7 that year. But for 130, well, it already has this 7 point cap associated with it. MIPS Pro, it automatically calculates all this for you. And all of that is presented on the performance screens when you can see how are these points dictated for these measures, how are the benchmarks being assigned to these measures, and all the data is right there for you. So I think that's good enough for benchmarks at the moment. I'm going to hand it over to Tara so she can chat a little bit more about measure scoring and then also dive into some of the nitty gritty, what we consider the fun stuff within MIPS Pro about how measures work, how they're calculated, activated, etc.
Great. Thanks, Josh. So this slide is going into the final scores for 2024 and the 2026 MIPS adjustment. Anything below 75 is going to have a negative impact. 18.75 and below is negative 9%. And between 18.76 to 74.99, it'll be on a linear sliding scale. 75, score of 75 will be a 0% adjustment, and anything above will be a positive adjustment, and that also will be on a linear sliding scale. Now we're going to talk about the calculation flow for measures. So measures are really do have a natural order of measure logic for every single patient in the measure. It's also called an order of operations. And within MIPS Pro, we have two main areas where we present and save that data. So we do have a clear UI component to help a user understand the data that is present, but we also have a way of drilling down into the data and really understanding where the gaps in care are in your eligible patient populations. And it's a tool to really help you fill those gaps in care and really get your points up. So in general, when measures are calculated, there are 4 steps. First, we find a code for a patient that makes that patient eligible and it activates the measure. We then assess for denominator exclusions. Even if a patient is somewhat eligible, there may be components to that patient's medical history that really doesn't make them applicable for a measure. So we'll take those patients out. We then follow through with a full denominator eligibility requirement that's provided by CMS. And once those patients are identified as being eligible, we then look for the numerator quality action. And really, that's where you're going to find if you do the numerator quality action, it'll be considered a met. If it's missed, then it'll be a not met. And that's when you look for those not mets and you really work those gaps in care, trying to get those not mets into a met status. So let's take that first step for measure activation. So for every visit, a measure is only answered if it's activated. If a measure isn't activated, MIPS Pro will show a blank row for that patient. So you'll see for patient, these are obviously dummy patients. M400_1 for measure one, it is not activated. Therefore, they did not have any of the eligibility criteria for this measure. However, for the second patient named measure one, you'll see that for measure one, it has a not met status. For this patient, they actually did fulfill all the eligible requirements, had no exclusion requirements. However, there is no numerator quality action that was identified by MIPS Pro, therefore, it's a not met status. Um, Measures can be activated in two ways. There is a manual way to activate a measure, and you can click that checkbox to the left of, you'll see in the screenshot below where it says measure number 9. There's a checkbox to the left. If you click that, it'll open up that that visit. We'll also activate a measure if there is a code that's ingested by MIPS Pro and that is it's an eligible question, a denominator eligible question, and that'll automatically activate the visit for that patient as well. Note that a measure will only be activated if the age and gender conditions are also met. If they are not met, then you will get a message that states that the patient is ineligible for measure due to age and or gender. So I've been talking about inclusion, exclusion, eligibility. Let's go into really what those terms mean. A denominator exclusion is a case that should be removed from the measure population and from the denominator before even getting into whether the numerator criteria are met. So they're used in proportion and ratio measures to help narrow that denominator down. For example, if you had a measure that was looking for foot exams, we would not want to include patients that had a bilateral lower extremity amputation. So we'll take those exclusions, apply that logic first, as there's no need to check even if that patient is eligible. This then will narrow down your denominator eligible population. It also increases efficiencies on the MIPS Pro side. Next, there are denominator eligible criteria. So that's the lower part of the fraction. It's your denominator. And it'll be the same as your initial population or a subset of your initial population to further constrain that population in order to get the right patients for which the numerator action should be applied to. Continuous variable measures don't have a denominator, but instead define a measure population. There are also denominator exceptions. You will hear that people will say denominator exceptions or numerator exclusions, I believe is what it was called many, many moons ago. So this is a condition that really should remove a patient or a procedure or a unit of measurement, even if the only if the numerator criteria are not met. So what it does is it allows for adjustment of that calculated score for those providers who potentially have a higher risk population. It also allows providers to exercise their clinical judgment on if that patient should have had the numerator quality action happen or not. So MIPS Pro allows for many different kinds. CMS identifies many different kinds of exceptions, but really it falls into three general categories. There could be medical reasons, patient reasons, or system reasons. And the numerator is the upper part of that fraction. It's called the measure focus. It targets the processes or the conditions or events. It also does can be identified as looking for an outcome. So this is what we expect for each of those patients who are defined in the denominator. And if it satisfies what's required, then that patient will be considered met, and it drives you closer to getting more points for your calculations. And I'm going to pass it back to Mike now, and he's going to give us a little insight into health equity.
Hey, everybody. This is also a very good time if you have more questions. We had a ton, so we might just pick out a few to ask our experts today, and then I will be getting back with most of you at a later time. So health equity, just from reading, and I know probably if you've been on these webinars, you're sick of hearing it from me. It is the most talked about thing in the final rule, the biggest changes, the biggest impact moving forward. What is health equity and how is it to be impacted? on our patient base, but CMS is working towards advancing health equity. It's not necessarily making everybody have the same exact type of healthcare, but making sure that everybody has the opportunity for the healthcare that they need in front of them. So eliminating avoidable differences, whether that is someone that lives in a rural area or a poorer area, in an urban area, or someone from a specific race or ethnicity or income level, uh, really taking the opportunity to make sure that everybody has the access to the healthcare that they need. And that's where a lot of these questions are coming in. There was a new measure for 2023 about health equity, and then a follow-up measure in 2024 on health equity. So I know that it is being impacted across all of the population and in any of these value-based programs that CMS is offering. Um, I know I have one slide on it, the health equity part. I do want to, before we even move further on, just just so you know that I do believe there will be more measures as years go by for the health equity. I think they're going to start making them mandatory for some of the programs that they have. For instance, if you remember back, way back in the day, in PQRS land, you used to have to ask um, for the meaningful use questions. Race and ethnicity was part of it. They took it out during during MIPS, but I do believe that at some point, just a premonition, nothing I know directly from CMS, that it will be coming back. A little bit about MIPS Pro today. Uh, MIPS Pro helps you report, track, understand, dive into your data, allows you to take a look at what's the best reporting options for you, whether it's MVPs, traditional MIPS, whether you're looking to join an ACO or a different type of APM entity. We utilize our best-in-class US-based support and integration teams. Our goal is to reduce your burden for reporting, give you the opportunity to maximize not only your incentive or your performance, but maximizing patient care by diving deep into your data and understanding where you can make changes today. We utilize our dashboards to give you insight into everything that you need for reporting reasons. And we're here to help with our full team and excited for the opportunity, as April 1st is the deadline for reporting with CMS. We highly recommend that you report before then and sign up. We are still taking people on to sign up for MIPS reporting for 2023. But if you're looking for 2024, our dashboards are up and running. Our measures team has done a great job of getting the measures on board and having the opportunity for us and you and your providers to start tracking, working on performance improvement, and getting where you need to go for all MIPS categories, whether it is quality improvement activities or promoting interoperability, or our MIPS cost analytics tool that allows you to take a deeper dive into the cost category and understand where you're going. Make sure you stay tuned for our next webinar. We should be putting on a webinar towards the end of submission season or early April will be our next webinar, and you'll be getting information from me shortly about that. You can always reach out to me directly. My email address is right here. You'll also receive an email directly from me in regards to the webinar. I'll send the slide deck as well as this presentation to everybody. But we have a couple minutes here, so I thought I'd go to a couple questions that we have and see if our experts can help us out here. So the first question that I have here is, why does a benchmark go away? Tara or Josh?
Sure. So benchmarks can go away usually when a measure is changed too drastically. So one example, as I mentioned before, is occasionally a measure is being topped out. It's being reported too frequently. It's being reported infrequently. Um, there are so many different ways why a measure could almost be a different measure because of the amount of changes that the measure steward wanted to make or that CMS requested that the measure make. If that's the case, then the benchmark is going to go away. the benchmark won't be, the measures won't be able to be comparable between years. So they need to start compiling more data for the measure. They need to basically start from square one. And then after that measure in its new form has been present for a few years, they'll be able to compile enough data where they can confidently put forward a benchmark to grade all the providers on.
Great, thank you, Josh. Next one up here. Uh, 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 what is the objective for suppressing or truncated measures? Is it just removing them in the following year?
So the objective of truncating or suppressing measures is if there's enough of a coding change that occurs on the ICD-10s, CMS really doesn't want to ding any providers because of the coding changes. So what they're doing is they want to truncate or suppress measures to really give the providers a chance to um, accurately and appropriately report on their eligible patients. If the coding changes so much and it no longer is applicable to the actual measure itself, then it's not fair to those providers who have been reporting based on those ICD-10 updates.
Great, thank you very much. Uh, uh, um, Hold on, I'm looking for. There's a lot of individual questions in here. You know, we had a question. What do you mean by cherry picking? Can you go a little bit into more of what cherry picking is? And I know I talked about it a little bit, but maybe you guys can discuss it a little deeper.
Yeah, so one of the ways that cherry picking is prevented is supposed to be the 75% data submission threshold. This idea that you're going to give us um, an honest snapshot or an honest take on the data that you have in your system, and that you're going to give us at least 75% of it. Um, Theoretically, it's pretty hard to cherry pick. The idea behind cherry picking is saying, well, we know that these providers treated these patients according to this measure, so we're only going to select those ones. We're going to only select the patients and the providers that did well, because then we'll get more points and then we'll get more money. Um, this idea behind cherry picking basically invalidates the whole point of MIPS. The whole point of MIPS is to get an accurate view of your data to help you learn where your gaps in care are, to help your providers learn how best to treat their patients and the areas that they need improvement. So cherry picking is not only harmful because you're essentially cheating and you're hurting other providers who are also reporting these measures. That data can affect benchmarks in future years and it can affect a whole variety of things, but also you're not giving your providers the opportunity to learn. You're not giving CMS an accurate representation of the measures. Um, and it kind of just makes everything fall apart. Is there a reason why CMS is so stringent in their auditing process about um, practices and providers who attempt to cherry pick data? And it's something that we try to emphasize because we know how much it can affect data, not only in the short term, i.e., if you get audited and you get caught, but especially in the long term, how it could affect at a grander scale, especially if many people think they can get away with it.
Great. Thank you, Josh. We do have a couple more questions that came about, but I think the big part is that most of them are individual questions about there. So I'm going to let us rock and roll here today, give everybody the opportunity to get ready for their next scheduled meeting, and we definitely look forward to working with you. And please feel free to reach out to me at any time. Once again, thank you very much, Tara and Josh. You did an excellent job. And as always, we appreciate you helping us out here. Everybody have a wonderful week and look forward to talking to you again. Thank you.
Thank you, Mike. Thank you, everyone.
Thank you.